So I'm tasked with Molecular Imaging 101. I'm going to try to give you an overview of what molecular imaging is in a very even shorter period of time than I'd expected. So we're going to cover a lot of territory, but I'd rather stop and explain something if it's important rather than try to get through all the slides, so don't hesitate to ask questions. I think we'll cover things of interest to all of you. We may not hit every specific interest, but I think a lot of this will make sense or have a piece that you can take.
Or you can make your slides available?
I can do that, certainly. Just by way of disclosure, I am a consultant for Eli Lilly Avid. And also, molecular imaging as sort of an intellectual disclosure is not something that's completely new. I think it's a new way of thinking about imaging, but nuclear medicine has been doing molecular imaging for decades. The tracers that we're developing are new and are based on increases in knowledge in the actual molecular processes involved in many diseases, be they heart disease, neurodegenerative diseases, or cancer. So we'll give an introduction, and I'd like to give some examples of clinical molecular imaging. Some are actually in current practice, and some are on the horizon. We'll look at oncology, heart applications, brain applications, and if we have time, we'll talk a little bit about PET MRI. PET MRI is not a specific molecular imaging application, but it's a new technology that allows either sequential or simultaneous acquisition of PET data, which is a type of molecular imaging, with MRI, which you may be familiar with, which is more anatomy and physiology. So what is molecular imaging? And there's many ways to define it. The way I like to think about it is it's a way of looking at normal, so things that happen in all of us all the time, or under special circumstances, or abnormal processes in living systems at the molecular level. And it's sort of that molecular level that makes it special. There's many ways to look at living people. That could be X-rays, could be ultrasound, but we're trying to look at specific enzymes, receptors, processes that are important, either normal biological processes or in diseases. So you can think of it as trying to see what cells are doing at a given time and also watch that over time. It's important both in clinical care. So we do FDG-PET, for example, for cancer on a routine clinical basis. That's a way of looking at glucose metabolism, and it tells us something about the cancer. But also there are many applications for research, some of which will never make it to actual clinical use, but can be very important for drug companies deciding whether a drug works or not. And we'll give you a few examples of these. There are many types of molecular imaging. So FDG-PET is shown here on your left. You can also do SPECT-CT, and I don't want to get into too much of the physics details, but it depends on what kind of radioactivity you're trying to detect. So PET and SPECT are classic nuclear medicine techniques for molecular imaging. In the case on the left, we're looking at someone with bladder cancer with a lymph node metastasis using FDG, looking at glucose metabolism. In this case with SPECT-CT, we're using a drug called MIBG that's labeled with radioactivity, that's looking at the uptake of hormones and neurotransmitters like norepinephrine. So this person has a pheochromocytoma, which you can see here. It's a type of neuroendocrine tumor that actually makes hormones, and to make hormones, it actually takes up precursors, and we can see that with MIBG and see where that pheochromocytoma is. There's actually also treatments you can do for this. If you change your isotope from I-123, it's a way to see things with SPECT, to I-131, which is a damaging radionuclide. So you can actually both see it and potentially treat it with the same drug. MR can do molecular imaging by looking at spectroscopy, and so these are different signal sequences you can see in glioblastoma, a high-grade brain tumor. And in normal brain, if you look at these patterns, the types of molecules present in normal brain are very different than the types present in most glioblastomas. You can also do bioluminescence. So this is basically a tumor. It's an experiment from my group just trying to prove that we actually had a tumor in this mouse. But the tumor has firefly luciferase. That's an enzyme that fireflies use to fluoresce. So you can see fireflies because they have this enzyme that creates light. And we can also use that in the laboratory. There's also fluorescence imaging. This is a glioblastoma. This is an intraoperative picture looking at fluorescence, and that helps the surgeon see where the tumor is, so they can take out the tumor. The idea, at least, is take out the tumor, leave as much normal brain as possible, but without leaving tumor behind. And then finally, there's more experimental techniques like using tagged bubbles for ultrasound. So the main thing is not to understand every bit of this, but molecular imaging encompasses a wide range of disciplines. And depending on the clinical problem or the clinical question, you may want to choose one or more of these. So how does this differ from, say, an X-ray or a CT? So we get functional and biochemical information, and I'll try to give you some examples of this. We can look at changes at the cell and tissue levels often earlier than we can see with CT or MRI. So one of the common things we're asked to do with PET, FDG-PET in the clinic, for example, is this chemotherapy working? And we typically, not always, but typically can see earlier on whether or not it is working based on the change in FDG, this glucose analog, sooner than you can see a tumor get smaller on CT. So we can help with diagnosis, prognosis, treatment planning by looking at specific molecular features. And one of the goals for both therapy and for imaging is to really personalize medicine. Randomized controlled trials are frequently done in several groups, but in the end, the treatment for an individual is kind of empiric. You have a trial that supports this use. We know it works in this percentage of patients. But if there's a specific mutation, like in the epithelial growth factor receptor, a EGFR mutation in lung cancer, you may respond very well to a particular drug. If you don't have that, you're not going to respond to the inhibitor. And so that's one way, if we could image that, we could know whether or not someone would benefit from a therapy. And there's many examples like that. Usually we're injecting probes into patients. So usually it's an intravenous injection like other medications. There are some exceptions. Just to give you a feel, another way of thinking about this is there's many different ways you can image people. You can get sort of anatomic images, so like a chest X-ray or a bone X-ray gives very, very nice anatomy. It's excellent. But it really doesn't tell you about what molecules are present in in those lungs or the bones. CT, similarly, gives you great anatomy, but not much physiology, not much molecular information. Ultrasound gives you some. MR can kind of span the spectrum, but it's better at anatomy and physiology. PET, SPECT, optical imaging shown at the bottom, those are frequently used for molecular imaging, and they're excellent for molecular imaging, but they sort of fall down a little bit when it comes to anatomy. We get very good images of processes, receptors, et cetera, but we don't place them in the body as well as you could with CT or MRI. But with hybrid imaging, we can get both. So now with PET-CT and PET-MRI, you can get your anatomic images shown on the screen on the left. So up here we have bone windows from a CT, which look pretty normal. But if you look at the FDG in this person with lymphoma, you can clearly see these areas of increased FDG uptake. That's metabolically active tumor. You don't really see it with the CT, but you see it. And now by fusing them, you can localize them. On the bottom, it's PET-MRI looking at cervical cancer lymph node metastasis. So you now can, in a single imaging session for a patient, either with PET-CT and probably in the near future with PET-MRI, get sort of the whole range, anatomy, physiology, molecular. And I think that's exciting because, sometimes when we're making new tracers or when we're designing new technologies, we don't think about, well, this requires the person to come back, multiple days or spend more time in the hospital. If you can do one thing all at once and get a better study, I think that's good for patient care. Another important principle is the tracer principle. For most of our tracers, we're injecting a very small amount of mass. And this is a rough, back of the envelope calculation, so it's not always true. But the amount we're injecting is often about a microgram. And to give you a sense of scale, a large grain of salt's about 60 micrograms. So, we're injecting frequently less than 1/60th of a grain of salt. And why that's important is we are injecting drugs that have biological activity. That's how we see our signal. But because it's so little, with very few exceptions, don't really perturb the system. So people don't feel an effect from the tracer. We don't alter the person's physiology. And usually that means that we can get away with using something that if you gave 2 grams of it might be dangerous, but at 1 microgram it really is safe. So it's both a safety factor and it allows us really to see what the system's doing without interfering with it. And so the tracer principle is important for many molecular imaging agents. Just to give you another feel, you might inject, 100 grams. So, almost 100,000-fold more iodine if you do an IV contrast CT. So to give you a sense of scale, and that's okay, but we're working at much lower levels than many other contrast agents you might use for medical imaging. So in terms of what are molecular imaging agents, so they're biologically active compounds that we can tag to localize our imaging agent over time. And just shown schematically, you can have an imaging agent that, say, binds to a receptor or is transported by the glucose transporter. It's somehow linked to a tag. For most clinical work, we're using radioactive tags, which allows to do PET or SPECT. But you could put an optical tag on there or an MRI tag, depending on what kind of tracer you're making and what you want to do with it. To be a little more concrete, we've been talking about FDG. So this is the natural structure of D-glucose. That's sugar. That's a common sugar. Your body makes it, uses it all the time. But if you replace one of these OH groups, one of these alcohol groups, with fluorine 18 in red, now you can, fluorine 18 is a PET radionuclide, so now we can see where this is with a PET camera, be it sitting in a test tube, be it in your body being taken up into cells, or be it in a tumor. So this is a very simple connection. This also changes the metabolism, so this gets trapped in tumors, and that's really one of the major bases of imaging cancer with FDG-PET clinically. So in terms of cancer, and we will get to brain and heart a little bit later, there's lots of potential uses for molecular imaging, and FDG does a lot of these currently, although there's certainly room for improvement. It's not a perfect agent. You can make earlier and more accurate diagnosis. You can get prognosis by whether a tumor has FDG uptake or not. Staging, is it a primary tumor and only in one place, or is it spread? And that's very important for many cancers for deciding how to properly treat patients. Choosing the correct therapy, planning therapy. Is this therapy working? And looking for recurrent cancer after someone's been treated. Those are very common things we do clinically, and these are also goals of new imaging agents for cancer. So we'll skip over this because for the sake of time. Here's that image of a woman with T-cell lymphoma. Here's a FDG-PET image. This is before she's been treated. She's been diagnosed. And you can see that there's lots of areas of increased uptake of FDG. Now, there's normal FDG uptake in the brain. The brain uses glucose as its major energy source, so we expect that. And there's also some urinary excretion, so that's just the bladder. But the rest of this is predominantly disease. And I showed you these images earlier as fusion. We can, with PET-CT, see this is bone marrow disease. But it's hard to see this on CT. And even if you did MRI, you would probably see this, but the MRI signal may not become normal for a good bit of time. So when this person got treated, they had a repeat PET scan to see if they'd responded. And so I think it's pretty easy to see this patient responded and did well. So you can see on your left the initial study, and on the following study you can see that disease is resolved. And there probably isn't another easy way to follow this disease in this patient other than FDG-PET. And don't want to get into a huge amount of data. This is a different kind of lymphoma, Hodgkin's lymphoma, but there's great interest in oncology looking at if we have someone who is PET positive after 2 cycles of chemotherapy, this is survival, event-free survival by over months. If someone has a positive PET scan after 2 cycles of treatment, they are much more likely to have disease progression than those who are negative. And there's a great deal of interest in, after 2 cycles of chemotherapy in aggressive lymphomas, if someone remains PET positive, if we switch the chemotherapy to something that may work, can we get them back up to those PET negative levels? So that's an example of, we do this for patients. The data is coming in about switching chemotherapy, and this is an area where FDG-PET has been very successful. I'm going to skip over this. Here's just another example of molecular imaging and how it can make a big difference, and kind of emphasizing the importance of hybrid imaging. So this is a man who has prostate cancer. What I'm showing you is a bone scan. This is a way for looking at areas of increased bone turnover. The great thing about bone scans is they're good at picking up disease. So if you see a bright spot in the bone, that means that bone's abnormally active. The problem is bone fractures, infections, prior surgery can cause increased uptake. So we're not very specific. So, the game to play with residents is which of these areas of increased uptake are cancer, and the answer is only one of them. So it's hard to tell from this. You can make guesses. The more you know about it, the better your guess is going to be. But if you do an PET-CT, you can see that this area has sclerosis, and it corresponds to the area of increased uptake, and you can then use this to guide a needle, which you see here, guiding the biopsy and proving that this is cancer. And unfortunately for this gentleman, this was recurrent cancer, but it's important to know rather than just watch someone when perhaps they could benefit from more aggressive therapy rather than just watching their PSA levels. There are some new agents for prostate cancer that are in clinical trials. I don't know if or when they'll become clinically available, but there's great interest. Yes?
I think a lot of people in the prostate cancer community would like to help try to get people into clinical trials.
Yes. And I would say one of the things, just it's kind of my punchline, but in addition to telling us as advocates, what are your priorities for your groups and for the patients you represent, and what we should be doing. We can try to generate evidence. We can try to get funding from the government or from industry. But another thing is you can be advocates also, saying to other doctors, saying like urologists, medical oncologists, saying to funding agencies, saying to Congress, saying these are priorities. Please, invest money in this, because a lot of this does come down to, do we have the money to do the trials? They're going to prove these things work. And getting people into trials is also good, encouraging them. Patient recruitment can be problematic for some of these imaging studies, and that's also important. This compound is an artificial amino acid called FACBC, and here the uptake you're seeing is in the prostate gland itself. And so one idea is by seeing the focal, in this case this is pathologically proven prostate cancer, is if you saw uptake, you could guide, sort of like that bone case I showed you earlier, this is where in the prostate you should biopsy. Don't biopsy blindly, biopsy this area. Another patient has a metastatic lymph node with high FACBC uptake, shown here. Prostate is an antibody to a membrane component of prostate cancer. It's a little better than CT, but it's not great, but it is clinically available and is used clinically. But you can see here it's much easier to see this area of prostate cancer. And again, someone who's been treated for prostate cancer has rising PSA but no clear sight. One potential avenue of treatment is you can retreat the prostate bed if that's where the disease is. But if it's lymph nodes, it's a different story. You either need to go after the lymph nodes or you need to do systemic therapy. And so, FACBC certainly appears to be better in the early trials than Prostate, although it remains to be seen how really effective it will be. Another strategy for prostate cancer that's been developed is these PSMA, small molecule ligands. And I know there's a lot to look at, but let's focus on the bone scan. There's a little bit of uptake in the spine, and in someone with prostate cancer, that's suspicious. Here's Prostate, and maybe you can see some disease, but it takes good eyes. But if you look at this I-123 labeled PSMA ligand, you can see very clear pelvic disease. You can see the bone disease. It's again, compared to Prostate, these areas of uptake are much more apparent. Because it's labeled I-123, there's also the potential for labeling with I-131. I-123 gives off a kind of radiation that's good to detect and get images from, but it doesn't damage tissue very much. It's, the dosimetry is similar to getting a CT scan. But you could change that out with I-131, which emits a different kind of radiation and is very damaging to tissue. So if you have a drug, like a PSMA inhibitor, that concentrates in the tumor but clears out of normal tissues, you can deliver a high level of damaging radiation. And so one of the exciting things in molecular imaging is that you can then pair them with a therapy. And so that's a great interest in this area. Let's talk a little bit about the heart. There's a couple of things to talk about. SPECT and PET are mainstays of cardiac imaging, and here we're really looking at blood flow. So sestimibie is a TEC agent for SPECT, and you can see that this rest image versus a stress image, this is just what's the blood flow at rest, but if you give someone a drug to increase blood flow to the heart, or you have them exercise, you're looking for the inability of the heart to adequately compensate for increased demand. So what we're looking for is a change between rest and stress, and if we see a change, we think that's an area of a heart that's not getting enough blood supply at stress. Now, if a part of the heart's dead, you don't see flow to it at rest or stress. one of the problems with SPECT is that you can get attenuation artifacts that you don't see with PET, and rubidium-82 is a clinically available PET tracer for cardiac perfusion. So here, if you were looking at the scan, you might wonder, are these areas of ischemia? Are they? But if you do PET, the higher quality of the images lets you more confidently say, no, this is nothing to worry about. Similarly, here's a patient that does have ischemia. Here it looks like there might be some infarction, but most people would call ischemia, but you can see this better with the PET tracer. Another application in myocardial imaging is, we're running over, aren't we?
What is the image you're looking at right on that previous slide exactly?
Yeah, it's difficult sometimes to present, but basically if you think of the heart along this axis, we're slicing it like a donut, and we're looking at slices of it.
Okay.
So it's not the whole heart, and it's always
Slice of the chamber?
right, right. I'll wrap up here. I'm sorry that we're a little rushed. There are some new PET tracer agents labeled with fluorine-18 that are being evaluated for myocardial perfusion. They're not clinically available yet, but if they are, I think they will increase the use of PET in cardiac imaging. There's great interest in imaging neurodegenerative diseases. Here's an example of using a PET tracer that binds the dopamine transporter to distinguish a normal person. Here we see uptake in the basal ganglia, which are where dopamine neurons terminate in the brain. These are lost in Parkinson's disease and some other neurodegenerative diseases. Whoops. And here is a patient with mild Parkinson's, and you can see it's asymmetric, so the left side's more affected than the right. And here's someone with more advanced Parkinson's. So this is a way to look at the dopamine transporter as a marker of loss of dopamine transporters. And this happens before people become symptomatic. So right now, that's not of great help because the therapies don't slow down or stop the disease. But if and when therapies do become available, it may be very important to identify people earlier and to follow whether the therapy is working. So this is a way to look at this. There's no way to do this with simple MRI, CT. This is really something only molecular imaging can do. There's also interest in doing this in dementia with Lewy bodies. Dementia with Lewy bodies, one of the features is a movement disorder component. Like Parkinson's disease, there's more to it than loss of dopamine transporters, but that happens as well. So here's someone who's normal, and here's different patients with various lost amounts of dopamine transporter from a clinical trial, trying to distinguish people with dementia with Lewy bodies from other forms of dementia. Finally, amyloid plaque imaging. There's a number of agents available. There's a number of agents that have been tested. Florbetapir is the first one to get FDA approval, but there's two other compounds that are in late clinical trials, and there's a good chance that these will become available too. This is not a diagnosis of Alzheimer's disease. That's not what these images show, but they do show beta amyloid plaque, which is a key but not the only feature of Alzheimer's disease. So here, all of these tracers show normal people on the left, and you can see white matter has higher uptake than gray matter, but you lose that in the positive patients. So there's great interest in being able to look at amyloid plaques in people with cognitive impairment to try to get a better diagnosis. This isn't the only way, this isn't the final arbiter of the diagnosis, but it's important information. And again, if you're trying to do a drug trial where you're targeting amyloid plaque, you're not going to ask people to get 6 consecutive brain biopsies. That's just not possible. But you could do 6 consecutive imaging studies to look to see if the amyloid is going away. So I apologize for the rush, but just to finish up, molecular imaging is currently a vital part of medical imaging and part of the standard of care for certain diseases. We have new tools for physicians and scientists to visualize biochemical processes both clinically and in research. There are new tracers and image systems that are rapidly evolving, so this is an exciting area of research. But there's been a bottleneck in exciting research and actually making a difference for patients. And that's an area where I think that advocacy groups can play a role. They can help steer us to what you see as the most important thing that we should be working on. And you can help with the funding agencies, regulatory agencies, reimbursing agencies, and industries to help us all work together to bring promising new technologies to patients. And then, like I said, please let us know what we can do for you, be it just simple education, but if there are big priorities that we can work together on, we'd like to hear it from you. Thank you for your attention. Sorry about the little bit of rush, and appreciate you being here.